initiative. And one of the parts of that we thought was really important was the patient voice. So we collaborated with Public Agenda, and today we are going to hear from them about how they crowdsourced ideas to build trust with patients and what they learned from that exercise. And so I'm very happy to introduce today Tristan Codrington, who is a public engagement associate at the Public Agenda. He works with Public Agenda's public engagement team to coordinate and implement engagement projects, including project design, field logistics, research, facilitation, report writing, and evaluation. We also have Matt Leininger, who is the Director of Public Engagement and the Director of the Yankelevich Center for Public Judgment at Public Agenda. Thank you. He leads their work in public engagement and democratic governance. Previously, Matt was the Executive Director of the Deliberative Democracy Consortium, an alliance of major organizations, including Public Agenda, and leading scholars working in the field of deliberation and public participation. And then finally, we are very lucky to have Gwen Darien, who is a longtime patient advocate and also a member of our patient advocacy and strategic planning committee for getting patient advice, who has played a leadership role in some of the country's preeminent nonprofit organizations. As Executive Vice President for Patient Advocacy, Engagement, and Education at the National Patient Advocate Foundation and the Patient Advocate Foundation, Gwen leads programs that link PAF's direct patient services to NPAF's initiatives to help ensure access to equitable, affordable, and quality healthcare. So I will turn it over to them for this very exciting presentation. Thank you.
Sorry, first rule, unmute yourself. Thank you, Kelly. We really enjoyed working with you and Daniel and Gwen. And others on this process. It was a lot of fun. We learned a lot. We really want to thank all the people that were able to join us for the process that we're going to describe to you. We learned a lot from them. And I think you'll agree that their insights are really interesting and helpful for understanding how to kind of to build greater trust, particularly in this case between healthcare providers, caregivers, and patients. Let me share my screen. And Tristan and I will take you through some of the steps here. Okay, you see that? All right, there we go. This is just the first slide for the entire process here, but basically why we did this. So the idea, and this is of course part of the larger Building Trust initiative that Kelly described, that obviously we know as part of that interest and analysis, we know that trust between patients and healthcare professionals is absolutely critical, that it's a two-way street. It's critically important that patients trust their healthcare professionals, also critically important that healthcare professionals trust patients. That is absolutely a kind of a bidirectional sort of thing. And we also know from a variety of research that trust has eroded, overall, this trust has eroded over time. So as part of this broader initiative, we wanted to kind of understand from leading stakeholders and advocates how they think about trust and what it takes to build trust. And finally, we wanted to kind of summarize some of the key trust building principles, and we're going to show those to you, and also encourage, as part of this process, encourage those stakeholders, the organizations they represent, and others to share successful trust building practices as part of this initiative. So, Tristan, why don't you take it from here?
Sure, thanks, Matt. So we conducted some interviews with 4 stakeholders to start us off, to really identify what are some of those major barriers to building trust. Before we start talking about how we fix the problem, we have to discuss what is the problem, right? And we'll talk a little bit about what we learned from those conversations. But after those interviews, we convened about 24 participants from all sorts of organizations, including patient advocates, researchers, staff in various foundations, and medical professionals, to really dig into these concepts of what are the different ways that we can build trust. And from that conversation that happened asynchronously online using Slack, which some of you may be familiar with for talking to your colleagues while you're not in the office, or even if you're in the office, we utilize that technology, especially this was during the heat of the pandemic. So, we had all been much more familiar with this, using these kinds of tools. So might as well apply it to using dialogues. So we used Slack for about 6 weeks or so, having this conversation. And then we had a final Zoom call to discuss the key themes. And the themes that emerged from that conversation developed into 5 principles for building trust from the patient advocacy perspective. And we're going to discuss some of those right now. So could we actually go back one slide, Matt? Yes. So
I didn't know if you wanted to talk about that one or not. Go ahead.
Yes, thank you. So opportunities for building trust. These were just some of the highlights from the conversations that we had about barriers to building trust. So first, we talked with Maya Sabatello, who is an advocate for people with disabilities. She's based in Columbia University. And we talked about lots of different things, including environmental issues, showing how American healthcare facilities are truly inaccessible to people with disabilities. And one of the quotes that really struck me was, it's so simple, but it's so true, is the fact that the ramp is not enough. Their postings in medical institutions rarely include Braille, right? That there are often stairs before you reach level ground. That OBGYNs don't usually have lifts to help pregnant women up onto examination tables. So there's this generalization of needs that she pointed out that fails to be inclusive of the variety of needs that actually exist and need to be accommodated. And this was the next one, attitudes and communication, a recurring theme. But a presumption that people with disabilities can't make decisions for themselves, and in these care settings, how the actual patients are ignored. And the conversation is happening with the caregiver, and it's assumed that the patient is not able to speak for themselves. But we also spoke with Kellen Baker, who's an advocate for the LGBTQIA+ community. And he spoke about different ways, he himself being a member of that community, spoke about different opportunities to best build trust with that community, including robust non-discrimination practices that are visibly posted around healthcare spaces. So again, the way you curate space can be in itself help to build trust. And in that case, being clearly indicating that discrimination against people in that community will not be tolerated. Cultural competency training, having information specific to LGBTQ populations in waiting rooms. Again, visible indicators of welcoming space, like stickers, pamphlets, pictures that include queer people. And finally, we also spoke with, I'm sorry, are you all able to hear me? Yes, okay, awesome. We spoke with Candace Henley from the Blue Hat Foundation, and we spoke about getting serious about historical and present impacts of racism in healthcare. That it's more than just a Tuskegee experiment. It goes way past in the past beyond that, and it continues into our present day. And it gets manifested in things like this disparities in outcomes for maternal health and infant mortality, and how Black women face extremely high rates of infant and maternal morbidity compared to non-Hispanic white women, and how these things are continually ongoing. And it's just something that just cannot be just pushed to the side and needs to be taken seriously, not only in the healthcare settings, but even before that in medical education. Next slide, please. Yeah, so the first principle, speaking of which, was addressing racial disparities in treatment. Speaking about recognizing the ways in which inequalities and systemic discrimination based on race, income, and other factors produce disparities in health outcomes. And we talked about different ways, and what you'll see here are these different tactics for building trust under this principle. So from a cultural point of view, encouraging the expansion of unconscious bias and racial disparities training. From a public health perspective, emphasizing preventative care, as I was saying about these massive disparities in health and health outcomes. Access, supporting Medicaid expansion in all states, or a form of universal coverage. And an example that we found in our research was the Greensboro Health Disparities Collaborative in North Carolina. So this is in the early 2000s. A group of community organizers in Greensboro were invited researchers from the University of North Carolina School of Public Health to form the Greensboro Health Disparities Collaborative. And that was an effort to understand and address the lingering effects of segregation. So again, having that historical perspective of understanding its impact in the present. And this was a really great collaborative example of this kind of research. And among the activities that it did, was conducting focus groups among Black and white members about their healthcare experiences. And after this really great initial research, they sought to test ways that they could develop customized supports for improving the experiences of Black women undergoing treatment for early stage breast cancer. And that was done in collaboration with Cone Health's Wesley Long Cancer Center and the University of Pittsburgh Medical Center's Hillman Cancer Center. And they were able to produce some really great results. Next slide. And this is a quote from one of our advisors, one of our participants in the dialogue. Assertions that patient mistrust drives disparities, obscures the etiologies of racial health inequities, and tactically blames affected patients, excuse me, for their disproportionate suffering. This is particularly true for Black patients. Any mistrust Black patients may harbor toward the US healthcare system is a result of their never-ending mistreatment, not the cause of it. Next slide. And I think, Matt, I'm turning it back over to you.
Well, I think, Gwen, if you want to give us some reactions here, our process as we go here, I think I should have said this at the beginning, was we'll go through each of the principles, get some reactions from Gwen, and we'll give you a little bit, we've got one more slide per principle, which is more about engagement tactics you might use in accordance with this principle. And we'll then invite the questions or comments from the crowd for a couple minutes and go on to the next principle. So Gwen, do you want to jump in here?
Yes, thank you so much. And Matt, would you turn it back to the first slide on principles? So I was, I've been thinking, I read all of the, I was part of this process, and then I also just reviewed these slides again and reviewed what we had talked about a few months ago when we came through this. And I think that one of the things that is still lingering in all of this discussion is there's still some of the language is still a little too polite. And it says address racial disparities in treatment. What we're really talking about is racism. We are not just, and racism that leads to disparities. We don't need to address racial disparities. We know they exist. What we do need to do is really work towards eliminating disparities in outcomes. It also kind of takes me back to some of our early work, and I remember particularly many of us remember was when President Obama was elected, people said, well, we're going to get to a post-racial society where we won't see color anymore. And one of the things that happened with that was actually the opposite, which is that it allowed racism to fester because we stopped talking about racism. We only talked about being colorblind and not looking at racial differences. We also saw it in the healthcare system in terms of things like personalized medicine, which could have either been something that created this kind of bridge where we didn't talk about racial about race, which is a socio-political identity. We talked about looking at people's genetic makeup. So I think there's some embedded both conclusions and continuation of language in here that we should take a closer look at. In public health, emphasizing preventive care, that sort of just completely just jumps over this whole notion of looking at the social determinants of health and the structural determinants of health. So what is preventing people from getting preventive care, and also what is keeping people from health? Because we're not just talking about clinical care, we're also talking about achieving health. The other thing, and Candace and I have talked about, Henley and I have talked about this a lot, is it was interesting doing 2 workshops, one in the Mississippi Delta and one in the south side of Chicago. Mississippi, of course, is a non-expansion state. Illinois is an expansion state. And the difference between what people, there's no doubt Medicaid should be expanded. I mean, there's no doubt in my personal belief system that Medicaid should be expanded to every single state, but it also means that along with that, there has to be appropriate access and attitude to equitable treatment, no matter what people's insurance status is. So could we go, and then to the next one. This quote that Kellen Baker gave from Boyd et al. Is a really powerful quote. And we saw this a lot, particularly in the early days of COVID and the vaccine rollout, where when we talked about Black, Indigenous, people of color, and they would say reluctance to get vaccinated, people would frame it within this idea of personal behaviors. But when we talked about somebody who had a different set of political beliefs and was not Black, Indigenous, or a person of color, we would also often frame it in personal choice. So I think the framing of how we look at this and what really these assertions are, and how we continue to blame people for their own health and their own health behavior, really very much changes from in between groups of people who we are talking about, whether it is in terms of racial or ethnic socio-political identity, or whether it's socioeconomic status or insured status or underinsured status. And so I think as we look at these principles, we really have to lift up some of the things that are underneath those principles and ensure that they are explicit, not just implicit.
Thank you, Gwen. And so for each of these principles, we're reporting on this process, which involved various kinds of experts, stakeholders, researchers who can comment on the patient, caregiver relationship and trust and all that, and kind of identify some of these deeper structural elements. It's also certainly quite a helpful thing. And it's the kind of thing you might be thinking of in your communities to actually be engaging large numbers of patients, residents, consumers, citizens in some of these kinds of questions. And so what we're going to try to do is for each of these principles, give you a few different potential tactics that you might use to do that. So for this one, for addressing racial disparities in treatment, I mean, one of the most kind of proven methods going back now 25 years or so for addressing issues of race are these small group kinds of community conversations on race and health that would involve patients, healthcare professionals, other community members. And those have a structure to them that's, again, has been kind of honed over many years of kind of allowing people to share experiences, learn together about issues, look at different options for change, decide together how they might plan for action and make change themselves. So that's one type of thing. Another type of thing that's a kind of a new innovation from 10, 15 years ago rather than 25 are the dashboards, online kinds of processes where you're allowing people to see the data. You're collecting the data and sharing it in a very public way so people can actually use that in the course of their discussions. And then finally, we found that it's very important to provide regular, safe spaces within institutions, and this could be among healthcare professionals themselves, to talk about issues of race and difference, to raise questions of equity in how they're working and how they're interacting with each other, how they're interacting with patients. That can also be a very productive sort of thing. Does anyone in the crowd here, do you have questions? Want to break in here with comments? We can take a few, and then before we go on to the next principle.
And you should be able to unmute yourself if you'd like to ask verbally.
Yeah, just jump right in. You can also use the chat and to ask questions or make comments. Maybe you're already doing that. I can't actually see it when I'm sharing my slides.
I am monitoring the chat, Matt, okay, and I will let you know.
Excellent. All right, we'll let, unless somebody wants to jump in here right now, we'll let you warm up a little bit and go on to the next principle, and we'll come back and you'll have another opportunity to jump in just a second. So this next principle, sorry. This is over to you, Tristan.
Right, thanks, Matt. And keeping in mind to make room for conversation, I'll try to move as quickly as I can. So our second principle was assemble a diverse leadership team. So that's speaking about not just internal leadership in institutions, but as well as ancillary structures such as patient family advisory councils. So working towards more diverse leadership in healthcare institutions to ensure that diverse perspectives and inclusive community groups are brought to the table. So we're seeing these principles here around government, tactics from the governance angle, ensuring that leadership positions reflect the diverse communities that are being served by an institution, from the culture of an institution, enabling people of color to participate at all levels of decision-making, education, support diversity and inclusion, training and medical education and certification, career pathways, creating career opportunities for a diverse workforce. And the example here, which is, may seem like a small thing, this Doctors Back to School Day from the AMA, but research has shown that minority physicians are more likely to practice in underserved areas and provide care for minority, poor, underinsured, and uninsured patients. So participating in Doctors Back to School Days helps students discover the many practice areas that are available to them, but also encourages them to consider other healthcare settings as well, including academic, research, and clinical. We know that it's not what you know, but also who you know that prepares you for many careers and for advancement. So nurturing these kind of relationships early on are important for raising new generations that are ready to be leaders. So not just saying we want more leaders, but actually support emergent leaders and create systems to support emerging leaders. Next slide. So from the dialogue, one of the important point that was made was don't silo people of color by relegating them to equity or diversity teams. So as we said from that tactic before, not just making available a limited set of decision-making power, but really opening up those opportunities. And we have this quote from Haladura, who is invited to the table and to be engaged is typically decided by leadership that lacks diversity and representation of communities of color, minority communities, marginalized communities, and vulnerable communities. That leadership also tends to not select diverse voices to lead their engagement efforts. The end result is that engagement work is not reflective of all voices, but a few voices. And over to you, Gwen.
Thank you, Tristan. And if you would just go back to the first one. So I think that, I think there are a few, clearly these are really, really important principles or really important ways of supporting this principle of a diverse leadership team. The one thing I would like to say is that diversity is a tactic. Equity is actually the goal. So the diverse leadership team should be to the end of having equitable and just healthcare for everyone. And so it's a really important tactic, but it's also an important tactic that needs an infrastructure and a support, as you've pointed out here. The governance, there are multiple levels of governance. I mean, there are some people, there's the board of director, there's the executive leadership team, there are pathways not just for career pathways are not just for a diverse workforce in the clinical field, but also a diverse workforce and a diverse community of advocates, of community leaders, of valuing many different kinds of expertise. So we see this, I mean, there are quite a number of really what I hope will be effective initiatives about creating a diverse scientific and clinical workforce. But I would also really encourage, particularly if we're looking from the patient and patient advocate perspective and community-based organization perspective, that we really create a diverse group of career and pathways support to train advocates, to train patient leaders as well. And then I would, yeah, because I think about this in terms of professional growth, and I think about this in terms of how we promote this throughout the entire kind of healthcare enterprise. Second slide, please. So the first point is a really interesting point because it is a really I've heard so many different sides of this argument and this conversation. I believe I believe in the principle through the dialogue, but I also know that in many places, if there hasn't been something that's been called out to deal with equity and inclusion and belonging, it doesn't happen. So it is I think that merits further discussion about the pros and cons, and it shouldn't be siloed, but it is where does this land in an executive or a leadership team, and where does it land throughout the entire course of an organization or a coalition of people. And then one of the things that that has been, I hear a lot from a lot of my colleagues is the idea that my colleagues who are Black, Indigenous, people of color, is that they're being asked to be the teachers. And it is, and don't put people in a position of being your teacher if you are not part of that community. It is a very, and people are being put in the position of being teachers to a group that then moves on from them as teachers, and then people are not integrated into the ongoing enterprise. And I'm sure many of us have been in meetings that have been facilitated by a minority-owned consulting group, but then you look at the participants and you look at what happens after that meeting, and it is the roles are very much the roles stay very much the same. So I think Hella Dura's point is really important, who is invited to the table, but who is invited to continue to sit at the table, not just who is invited to the table for one time, is incredibly important.
So some of the engagement tactics you'll recognize are things that you could use for many different kinds of purposes. The first one here is one that's true of this, but in terms of assembling a diverse leadership team and understanding and who the leading voices are in a community, these simple listening sessions, 30 minutes long, 20 people or so, can be very valuable. And you'll find often that there's leaders that you meet, who are already leaders in the community or in different communities that you kind of step forward in that way. We've also used serious games a lot as kind of an initial kind of phase, initial kind of team building, leadership building sort of phase in engagement. And Tress and I have done this a lot in New York City. We use games that help people learn about the issues, that they're fun, they're kind of an event, and help them learn also about kind of engagement, the opportunities themselves. And we've done games, online games you can play face-to-face, things you can do through Zoom or whatever as a group, and we've done them based on things like Jamaican Jeopardy or Family Feud. There's various kind of trivia-based games, and one of the virtues of those is that you can kind of present knowledge in a way that validates the knowledge of different people. Patients know things that are important that healthcare professionals should understand. Healthcare professionals know things that patients need to understand. So Jeopardy, where you've got kind of the different columnists or different things, and Family Feud with the same way, it allows you to kind of validate different sources of knowledge. You can also do crowdsourcing exercises on key issues. That's a relatively simple, relatively kind of convenient online way that people can kind of step forward and get involved in something. You can often find leaders that way. And then also, once you have convened leaders, it's critically important to help them engage others. They will typically come to the table and think that they are representative voices, and that's all you're asking them to do. But you're going to get more out of them, and they're going to become more powerful and influential if they can actually find ways, with your help, to engage more of their peers. People have questions or comments on any of those sorts of things before we rush on?
Yeah, so we do have a comment in the chat box that says language has evolved regarding racism and anti-racism. I'm not sure, Daniel, if you want to say anything else to that before we ask Matt and Tristan and Gwen to respond.
Well, it's great to hear their voices and see them. And it was great to work with them on this project. And Tristan really provided lots of leadership. But I'm going to put this back to you guys. We were the recipients of all this, and we do think that the language has evolved. I think it's a testimony that we're more comfortable now with language like anti-racism and anti-racism organizations. And I think that's a testament to people discerning over a period of time what those things meant and discovering and reading. And so I think it's great. Maybe we should do, some revision of some of the language to make it intended. It is interesting to me, and I was commenting to staff today, that the first thing that came out was something about racism. The last thing to come out, and I remember pushing the group, was about the patient-physician relationship. So I just think that's interesting to note that this group started out at a much more macro level and really focused on racism. And at the last principle, as you'll see, is about the patient-physician relationship. Usually it's the opposite way. And I think that reflects the kind of the leadership level of this group, that they started out in the highest level. So good to see everybody. And if I would direct people to our website at Building Trust, where I thought we did a good job in displaying the information.
Awesome, thank you. And that I think you're exactly right. And I think that reflects a larger shift in terms of thinking more and more about the institutional facets of racism and trust, and more practically about how you can affect those. So I totally agree with that. Principle 3.
All right, principle 3. Encourage community and government partnerships. So that's about fostering sustainable cross-sector partnerships among community members, health systems, and government to more effectively address social determinants of health. And that thinking is coming from the fact that social determinants of health are broad-ranging and deeply entrenched. So the strategy to address them should likewise be similarly broad-based and long-term. So as we think about the tactics, culture, inspire physicians to prioritize quality of interactions over volume of patients seen, payment, ensure reimbursement, reward value rather than time spent in patient caregiver interactions, access, support increased implementation of language translation services, communication, encourage meaningful conversations between physicians, patients, and caregivers. And our example here, I'm sorry, is this the right slide?
I think so.
Mm-hmm.
Okay. Sorry, am I looking at the right thing? Okay, I think we might have a little typo here. So the example from this one actually is, you'll see it on the Building Trust website, is the Central Oregon Health Council. And that was about improving healthcare and bringing down costs and raising both quality and satisfaction. And this council existed to build equitable and integrated health ecosystem that improves the health of Central Oregons through collaboration and partnerships, data-driven decisions, quality improvements, lowered costs, and empowered providers. Next slide, please. So a point from the dialogue about putting more time and effort into locating community leaders who are not formally affiliated with an incorporated organization, thinking about how you can go beyond the usual suspects, if you will, the people who you first think of to engage when it comes to representing the community might be people who are actually overrepresented, who might not represent the full breadth and diversity of the community of your institution. So we have a quote here. In addition to developing partnerships between community organizations, members, and health system and policy actors, there is an important need for spaces and opportunities within communities, however that's defined, to discuss priorities and develop a collective agenda so that when individuals are invited to participate in partnership efforts, they're bolstered by the power of a diverse constituency. And that's from Lauren Weschler of the Philadelphia Health Partnership.
Should I go back, Gwen?
Yes, please. You know the routine now. We go back. So I have a few comments here. I mean, you'll see there are a lot of themes in all of these comments in terms of what the dialogue was with the people who participated, and then also in the conversations that obviously Tristan, Matt, and I had. One of the things that I think that in terms of culture, first of all, I think in terms of culture, just relying on the physician and in the culture section, we're missing a lot of aspects of culture, but we can talk about that a little bit further. But I will also say that quality isn't always equated with time. You can have incredible quality relationships and interactions. And it depends on how the connection is made. And so you can be seen and heard and understood in a shorter period of time than people often think. So we tend to kind of go back to this time issue, which I think is clear. It is an issue. But time doesn't have to be the same for everybody because quality means different things to other people. And I will just say from personal experience, I was yesterday, was my graduation visit with my breast oncologist, which is so exciting. I don't have to go back again. And we had a very short visit, but it was a very, very rich visit. And I didn't miss the time. I mean, I could have talked to her for a long time, but the amount of time we had did not change the way that I felt about that visit. I felt like she knew me, she saw me, she got directly to the questions that needed to be asked. So I would just say that there are different ways of looking at quality of interactions, and we should think about that as we think about the reality of where we're living right now and the time that everybody has. And payment we talk about a lot. The other thing I always think about is that access. We have got to focus on equitable access, and it is not just about language translation services. That's also a little bit of cultural reductivism. Not everybody whose first language is Spanish comes from the same culture. Not everybody whose first language is Chinese comes from the same culture. So we often tend to do things like say we have to have a Spanish language publication, but that doesn't really address culture. That just addresses one very small aspect of culture. And then communications, of course, it is not just about, it's about skilled communication, but it's also about active listening. And one of the places where I think that these relationships really fall down is in listening, not in speaking. And I want to make sure that every time we talk about communication, we don't just mean speaking to someone, we also mean listening to what somebody says. Next slide, please. And I think one of the other issues here is that I think there's a step that we've skipped a little bit here, which is that we spend time in a community creating a coalition of groups in that community and and work with communities to identify who the right people are. And so what the most important things to that community are, that the issues and the barriers that they want to solve to achieving health for everybody within their community. So it is more than just locating community leaders. It's about locating multiple leaders who help locate each other, but also identify the problem, they identify the barrier and identify the health outcome that their community wants and deserves.
I'm going to go fast here. So a couple ways.
Oh yes, we are getting.
I'm sorry.
Yes,
in terms of encouraging community government partnerships, that various kinds of more elaborate summits and planning workshops that can bring together patients and various kinds of stakeholders, healthcare professionals, can be very important for those partnerships. Also processes like participatory budgeting, which is a way for people to kind of come up with ideas, figure out how to kind of refine and improve those ideas, and then decide together from a shared pot of money, vote on which of those ideas or how to allocate the funding among those ideas. That's often, in many cases, in many issue areas, a great way to kind of establish stronger partnerships between institutions and other grassroots groups and individuals.
I mean, can I just say one more thing before we moved on, which is we talked about this a little bit earlier, that there has to be equitable pay for all partners when you're having community government, healthcare system partnerships.
Right. Yeah, no, that's critical. Anyone else have questions or comments? Someone jump in right now.
There are actually lots of comments and questions,
okay.
so I'll try to pull a couple of them. So Bill Adams mentioned that you can engage with communities by not leading, but also opening up healthcare facilities for communities to develop themselves and improve health. And one of the ways that you can develop leaders is by inviting people into your facilities and into your meetings. Wilma mentioned also not all communications is verbal. The nonverbal language is also important. We have a exclamation point for what Gwen said about quality, that it is an important point that quality is different for all. We also have respectfully, I think, more language that includes all clinicians and providers is warranted in conversations such as this. MPs are providing primary care to medically underserved areas, and for many others, they are the PCP of choice. You can be in the community without leading it. And again, perhaps we move away from, and we are at the ABIM, but we do need those reminders to move away from physician-centric languages and talk about all of the care providers that are there. And there was a lot of agreement with that.
I also saw Wilma, I think Wilma Alvarado's square light up. Did you want to jump in here verbally?
Yes, thank you. Thank you for that. And one thing, because, you know, this is, I have to say it in this group, I feel that you all have created the space for a trusting opportunity to speak. Translation is the written communication. So if we're going to be sitting there writing back and forth to people, then that's the correct term. Interpreting is the oral communication. So I just wanted to put that out there. There's sometimes two different skill sets. And then, you know, my comment about, and thank you for allowing me to share that and creating the space. And I agree with Jill's comment. Communication is about being heard. So to me, the provider is the person who calls me to do that pre-interview before I go into a procedure, the person that checks me in, because if they're not even going to look up to engage with me and just ask me for my insurance card, then by the time I get to my physician, I'm not going to feel that there's an opportunity of trust. So even the person who's taking my vitals, if they're not listening to me as to why my heart rate might be elevated, or I might sound like my sinuses are bothering me, then by the time I get to my provider, you know what, I'm done talking.
Right.
So, and then also as a woman of color, this is already, you know, there's that implicit and unconscious bias. Oh boy, here comes this patient, you know? And so I'm now objectified. I'm a patient and not an individual. And so these are some of the things that I think may happen. I choose to think they happen unintentionally and not maliciously. However, they occur. And if I'm able to advocate for myself, I think about those who are not. And what they do is they choose not to come back.
Thank you. Thank you. Great points. Let's zip through our last two principles here if we can. Go ahead, Justin.
Yeah, and oops, my camera's off. How did that happen? Okay. Actually, let me skip to principle number 5, because I think we had a little bit of a text mixed up. And we actually were discussing some things around prioritizing the patient-physician relationship, ironically, after Daniel brought that up. So I think this is kind of more related to the conversation we're having right now. So I actually read several of these things. A little bit about this example from BMC Medical Education. So they did a study on the new patients and their perspectives around that. And the focus population was people living with HIV. So it's a discussion around how new patients are particularly a vulnerable population because they can be high risk for missing subsequent visits or dropping out of care completely. But there's a few existing data on what new patients value in the beginning of a relationship with a new provider. So in the study, the patients described significant anxiety and vulnerability, not just from the HIV that they had, but also in starting a relationship as a new patient to a new provider. So the analysis from the study revealed 5 actions that providers can take to reduce patient anxiety or new patient anxiety and build trust early. So 1 was providing reassurance to patients. 2, tell patients it's okay to ask questions. 3, show patients their lab results and explain what they mean. 4, avoid language and behaviors that are judgmental of patients. And 5, ask patients what they want. Matt, we go to the next slide. So a quote from Stacy Chang from the dialogue was that one source of mistrust is the sense that people get, whether they're walking into a clinic or trying to find information about their health insurance, is that the system is focused mainly on the needs of companies, care providers, and the institutions rather than the needs of patients. A way to rebuild trust, therefore, is to assess all these systems through the eyes of those receiving care and their lived experience.
Gwen, do you want to jump in on any of these?
I think that I've said enough. I think I would rather, no, but I think that's a really great quote to ask the people in the audience to comment on.
Yeah.
Since we have 10 minutes left or 12 minutes left.
There's a couple, well, while you're thinking on that, a couple of engagement tactics that are kind of fit this one. One, simple interviews you could be doing, in the same kind of data gathering way that the example that Tristan just described. And then also you can be using texting in kind of creative ways. There's ways of using texting as part of an engagement process where basically you can support conversations that are decentralized. Basically, so a healthcare professional and a patient or the person's family, in a small group can actually, using the phone, if you set up a script for them, can actually go through a set of discussion questions, answer some of those questions together, see what other people answer to the same questions, and kind of get more information, more links that way. So there's ways of using phones and texting as part of engagement processes that make them a lot more conducive to this kind of patient-physician sort of setting for engagement. Thoughts, questions from people about Stacy's quote or any of this? Interesting. Do we miss anything critical? I think we had 5 principles. We really only had 4. Maybe
no, we can go back to number 4. I just skipped because it was just relevant to the conversation that was happening.
Okay. All right.
And I'll say right before you go, we do have
Sure.
the comment from Bill Adams that says, let the patient tell their story. Until they trust you, they will not tell you their whole story, which is a great point.
Absolutely.
And fortunately, this is one of the shortest ones. This was like a smaller point that we heard from folks. So there's not much to share from my end on this about promoting data transparency and security. The actual principle: ensure greater data transparency and accountability in both safety and quality reporting, with the focus being that patients receive clear information on what the patient experience will be like. So some tactics: ensuring data includes information on race, ethnicity, language, disability status, sexual orientation, and gender identity. Analysis, recognizing biases in algorithms and in the collection analysis of data. And this example from the American Institutes for Research, they developed principles for making healthcare measurement patient-centered. And those 5 principles are: 1, making it patient-driven, so that patients' goals, preferences, and priorities drive what is measured and how performance is assessed. 2, making it holistic, recognizing measurement should recognize that patients are whole people and consider their circumstances, life, health histories, and experiences in and outside of the healthcare system. 3, transparent, making sure that patients have access to the same data as other stakeholders and understand how that data is used to inform decision-making around care practices and policy. 4, making it comprehensible and timely, such that patients and other stakeholders get timely, easy to understand data to inform decision-making and quality improvement. And 5, it being co-created, so that patients are equal partners in measure development and have decision-making authority about how data is collected, reported, and used. Next slide. We have this quote from Chuck Bell from Consumer Reports. We did not talk so much yet about healthcare quality and safety and how to address problems with medical harm. But for those things, data and transparency are also keys to accountability. We should want to promote effective patient engagement and informed decision-making, which doesn't always come from blindly trusting that the folks in the white coats have all the information.
And a few kind of engagement tactics that kind of fit this data aspect. One, holding kind of learning sessions, and they can be doing these online or off, that kind of describe, you know, for people how data is being used. Most people don't understand the very pervasive role that data collection practices are playing in healthcare and lots of other aspects of life, and gather feedback from people about it. You can also kind of attract and convene people with tech skills who are kind of civic tech sorts in the community, and hackathons, various things that you can invite them to use the data in ways that will be helpful for people. And of course, you can be conducting surveys about how people feel about data transparency and privacy and use. Oh, I think you're muted, Gwen.
I'm muted. I would also add one thing, which is that the data should be returned. Any findings from the data must be returned to the community and to the people who gave those findings. Yeah. And that it is also really important that people understand what is being done with the data that they give, or what they're participating in, what is being done to better the health of people in their community and in society, so that it's not just a one way. I mean, so much of what we talked about today is about multi-directional conversations and benefit, but it has to weave through every single principle here that there is, and we have to understand what our value is as patients to this project, to the project of ensuring health for everyone.
Cool. So before we turn it back to you, Kelly, to kind of, I guess, wrap us up, any final thoughts or questions or comments? Either could be from the chat, or people want to kind of speak up now.
I will say, I'll add that, you know, the examples that we shared for each of these principles are really rich and have a lot of information that we can all learn from. I know I had to breeze through some thick stuff really quickly, but again, all of this is accessible on the Building Trust Patient Perspectives website, as well as the links to reports or about all those examples.
So we do have a few more seconds. So if anybody has any more comments, questions, you're welcome to speak. I will say that I did put the website that we've referred to in the chat. And so you can just click on that link if you'd like to see the great work that these wonderful presenters have done.
We can also share the slides, you know, that people can, and if people have questions about the slides, feel free to email us after the fact.
We'll also be posting this recording to Workplace, and we'll have the recording. So if there's somebody you think would find it useful or meaningful, we're happy to share that with you as well. Hearing no comments, I know everyone loves 5 minutes in between the next meeting. So I will thank you all for joining us today. And thank you so much, Matt, Tristan, and Gwen, for giving such an engaging conversation. And I hope everyone will join us in September. We're taking August off, but join us in September for a trust conversation with Shantanu Nundi, who's the Chief Medical Officer of Accolade. That will be on September 16th. So I hope you stay cool and enjoy your summer, and hopefully we'll see you again in September. Thanks so much, everyone.
Thanks, everybody.
Thank you, everyone.